Thank you for this wonderful opportunity. I thank AIC for having me here. Well, I'll be speaking on, as you say, posterior, this Phaco in pre-existing capsular lens, and I think nothing more than that. Posterior polar cataract is the thing which comes in your mind because of the inherent weakness and the thinning of the posterior capsule, enlargement of the specification. And generally, they have a central vertically oval defect, thick fibrous margin. You could have pre-existing PCRs even in congenital cataracts like posterior lenticulus or posterior persistent hyperplastic primary vitreous, where they have a stalk, and when you're going into the floating with the vitreous, the fiscal sign that could have an absent PC, or it can have a very thin PC there. And of course, trauma, both penetrating and blunt trauma, are because of pre-existing PCRs. Now let's come to the Phaco tips in these cases. I would say choose an advanced Phaco machine, especially if you know that there is a pre-existing PCR. Keep the vitrectomy ready. Self-sealing incisions, very important. And avoid hydro procedure in these cases. If you are doing it, do it with a viscoelastic, low flow machine parameters, Phaco in situ. I mean, don't move it too much. An adequate visco to support your opening that is there. Use second instrument to stabilize the nucleus. Avoid changing nucleus with the Phaco probe, and do not panic. And of course, you need to have a standby VR surgeon. Let's come to this PPC, the commonest that we find when there is a pre-existing PC. There is a small hole there. I could see it pre-operatively. So I go with all care and attention to not do hydro procedure just with a spatula. Go it and do a small central trench, put in viscoelastic, and then this is the hydro delineation. Separate that central part, and then put in enough viscoelastic not to hyperinflate the bag, the eye as a whole, but then keep it just enough. And with the present machines, you can have the bottle height, or the Centurion machine, you can keep it around 30 as the irrigation. And then as I'm going and taking, I know that somewhere now I'll meet the PC, and the moment I see it, well, there it is. I stop it here, put in a high monopolar viscoelastic, in this case, viscoat, no financial interest, but that really serves as the real plug. I can see a bit of horizontal tear, because most of the PPC tears, as they happen, they are either horizontal or vertical. In this case, it was a horizontal. I could see it, and then plug it again with methyl cellulose over viscoat. And then this was a soft, as you can, most of these cases are soft, so I can do a visco aspiration and expression, and there I express it in the visco. And once that is over, I go on with dry aspiration. As you can see, I put in viscoelastic from the side port, keeping the tear that is there. I try to identify it. It has gone right up to periphery. As you can see, it's a totally horizontal break. There you are, the horizontal break. But then now, since I've completed it, the option before me is putting in a lens which is either totally in the bag, or in this case, I'm choosing to put a multi-piece lens in the sulcus, and then uh, do an optic capture. As I go and put the lens, I do lose a bit of vitreous. Then I go in with this cutter, but ideally should go from the side port. But the same, since the chamber was full of viscoelastic, I just did not put any infusion there. Then later on, I just go forward and do a from the side port a little bit of vitreous that had popped out, but then the surgery is completed. Now, this is a blunt trauma. Well, I knew it from the patient's record before the cataract. And this is a young child of 8-year-old came to us with the total cataract, which showed that 6 months back he had taken a picture where there was a pre-existing tear. As you can see, I could see there is a through this white cataract, this horizontal line. Do a capsulorhexis. Be very careful that the rhexis is around 4.5 to 5 millimeters, so that in case I cannot put the lens in the bag, I can do a lens in the sulcus and optic capture. As I do bimanual eye, this is a child, 8-year-old child, as we do take the aspirate the soft cortex. There's hardly any nucleus, and you can see that is the horizontal break over there gradually, and put in. You can see the Centurion parameter showing around 40 IOP. That's just enough to keep, and so that I don't have any stability of the chamber, instability of the chamber. Do a aspiration, bimanual aspiration. See the break is still there. Bimanual, yeah. As I go in now, there is a break there, and I've got the intact bag. So here I decide to go in with the uh, single piece lens. The lens goes into the bag, and I complete the surgery. In this case, the surgery is over. So this is another blunt trauma. Well, basically, I was not aware of it, that whether there will be a break or not. But then, as we go forward, I do a bit of hydrodissection, and then this is the in situ emulsification. And as I go forward, I do see there is a rupture there already. So fibrosed, the margins are fibrosed. As you can see, this is the fibrous margin of the rupture, but still I could manage to put in the lens in the sulcus without losing, without having much of a problem, and the lens goes into the sulcus. Now this is a penetrating trauma. Now this is again, see, I can see the penetrating mark. Well, whether these the needle, they gave a history of needle injury. This was again a small child, came to us after 6 months after the injury, and again the same thing. I go ahead with the rhexis. As you can see, the rhexis is here. And this is the area where there's an injury. The injury mark is there, and you can see, and not know whether it has ruptured the posterior capsule or not. Do a irrigation just to take this line and take out the cortical matter. And as I go forward, I do see a big break there. But fortunately, as you can see, I'm already pulling on the margins. There is a little bit of vitreous there, so I stop it there, and then just do not go in the central part. Go to the periphery, take out all the cortex. You can see, take out the cortical matter from the periphery. And once I do that, I go ahead with the vitrectomy, and then I have enough space there, as you can see, and put in the lens again in the sulcus. The lens is placed in the sulcus, and there, once that is over, putting a bit of triamcinolone now, yes, there, to check if there is any vitreous there. Once that is done, I know the integrity, and since I was a small child, I continue with the vitrectomy and try to get any vitreous stance that is there. Once that is done, I suture the incision. Again, as I said, it's for 8-year-old child, so I didn't want to leave it that. And of course, the last case, this was a blunt trauma. And as he went ahead, we just separated. There was a history of UVITs, and then go ahead with the rhexis. Once the rhexis is completed, I did go in, install the Phaco Pro. Then the rhexis again, the needed size around 4.5 mm rhexis. The moment I go into the IH, the whole nucleus drops, and that is the pre-existing break that was there. The VR surgeon comes in and removes that. You can see that's the pre-existing break already there. So the nucleus is removed, and once that is done, put in again same, put the visco in the entry chamber, and put in the lens in the sulcus. Yeah. So lens is in the sulcus. Well, again, a capture. The optic capture is done. That's the preferred method. Once that is done, the lens works out. So thank you. Thank you for your patient hearing.
Yeah. That was very nice presentation.